the title has this second part. With this presentation, I will also share with you some data science experience. Okay, yes. This is the cancer prevalence in Taiwan at the end of 2021. For colorectal cancer, we have about 150,000 people had colorectal cancer diagnosis in their before that time point. Among them, 28,000 were colorectal cancer in situ. So we can see the previous talk is very interesting. And also for breast cancer, the number is nearly 200,000. And among them, 28,000 were breast cancer in situ. And in the middle lines, you see this for liver cancer and lung cancer. These are the 4 most common cancers in Taiwan in terms of incidence. And these numbers is about, in 2014, the total cancer survivors in Taiwan is about this number. So you can see this number is very, very alarming. But I'm not going to focus on these numbers. I will talk about survival of these people. So the first message today is that cancer-specific survival in Taiwan is improving. The second one is that for these people, we need to know the actual prognosis. For example, 5-year, that is categorized by age, sex, stage, and the comorbidity level. We would like to know what's the probability that they will die of cancer, the probability of die of other causes, and the probability of surviving. And finally, I will tell you that the effect at the population level of tyrosine kinase inhibitor in Taiwan. I'm sorry, I'm not good at handling this kind of thing. Okay, yeah. From the data science perspective, I will tell you 3 things. First is that we can use the Taiwan Cancer Registry and the Taiwan cause of death database to pretty reliably infer the cause of a death for each cancer patient. And this is then followed the algorithm developed by the SEER group in NCI. And the second thing I want to tell you is that we need a cancer comorbidity index, because when you talk about the people dying from other causes, there are so many possibilities. How do we summarize them into a single index? Again, this follows the development in the US. And here we need to consider training set, validation set, and a test set, and to utilize the basic phenomenon in data. That's the bias variance trade-off. And finally, I want to make some comments on this cancer epidemiology metrics. So cancer survival in Taiwan is improving. We published the paper in 2018 together with Liu Chang. I learned so many things from him about oncology. And for this 20 most common cancers, we consider 6 age groups from 15 to 94. And so there are 120 cancer sites and age group combinations. Among this 120, 49 showed improvements in the 5-year net survival in this 2 time periods from 2000 to 2004 and 2005 and 2010. This improvement is assessed by 95 confidence interval and also by the number. Only for cervix uterine cancer in the age group from 35 to 49, we see some deterioration. So generally speaking, we can say that cancer survival is improving. Here we need to use the concept called 5-year net survival. In this presentation, I always consider 5-year survival. Net survival means that the survival, we assume under the condition that the cancer patients won't die of any other causes. So this is a very idealistic situation. In practice, the best way to estimate this is so-called relative survival. That is, you compare with the survival of patients, of individuals without, say, breast cancer, with breast cancer and without breast cancer. Otherwise, they are about the same. The relative survival is considered the most reliable way to get this net survival. Another is cause-specific survival. If cause-specific survival can be observed, can be decided clearly, like in a clinical trial, then that's something we trust. But in a population level, we need to show that these two are close. And if they're close, then cause-specific survival can be, this criterion can be used for other studies. And why we need to consider this net survival? Because we want to compare the survival between groups, between time periods we needed. And this cause-specific survival algorithm was developed in NCI, this published in 2010, and we adapted it in Taiwan. And we show that based on Taiwan data, cause-specific survival and relative survival are very close. Now, with this understanding, we can quite confidently to apply this cause-specific survival to this epidemiology study. So with this, then we are in a position to consider this actual prognosis of older patients with the 5 most common cancers in Taiwan. Why older patients? First of all, because there are so many old people now in Taiwan and with cancer. Secondly, we want to compare with our results with those published in US. So the probability of dying from cancer and the probability of dying from other causes, what are the other causes? In 1985-86, Charlson comorbidity score appeared. It is a way to summarize this chronic conditions for this kind of survival study. And then NCI developed a comorbidity index around 2015. And it all based on a survival model, a Cox regression model. The event of interest is the time from cancer diagnosis to non-cancer related deaths. That's event of interest, and what are the covariates, what are the risk factors. There's so many. So this is the list that we consider in Taiwan, but it's a little bit different from those in the US. But then the question is how to decide these conditions for one thing, and also what are the training data sets? Should we combine all the breast, colorectal, this cancer together, or we need a cancer-specific comorbidity index? So you can see a lot of decisions to be made. But finally, we decide one thing, that is for the comorbidity assessment, we consider the time period 6 to 30 months before cancer diagnosis, so that it's something not influenced by the disease cancer itself. Eventually, we need to get a survival model, a Cox regression survival model that has a good discriminatory accuracy in predicting death due to non-cancer causes. So with this data, and you can see that a lot of dirty work to be done. We have this. I won't go into this, but then I can assure you that we are following the standard procedure in data science to build this prediction model and get this index. And for this, I'll show you something. You can see this is finally this model we have. That is, this is a Cox regression model for, say, I don't know if you can read. Pointer is not working with me. For CVD, let's read this COPD. It has this coefficient, relative risk coefficient of 0.26, and correspond to an odds ratio 1.3. So we have this. These are readout from the Cox model we developed. So to get this Taiwan comorbidity, cancer comorbidity index for a patient, you just add up the coefficient I showed you there. And for the comorbidities that this person had. So here a list of this coefficient, relative risk coefficient. For CHF, congestion heart failure is a 0.75, dementia is 0.66, and so on. And COPD is a 0.26. That's very different from what we see from the West. And we don't find ulcer or mild liver disease in our model because the AOC won't get larger if you put in these two items. Just to show you this, and you must, I have to tell you that I discussed this so many times with Chang about should we put in there, should we not? I said, according to data science, no, we should ignore them. But then we also need some interpretation. Why? So he told me, he showed me some of this literature. Okay, then we classify the comorbidity level into 3 levels. For those without any of the 18 comorbidities, we say that they had this level 0. And for those who have CHF, COPD, CRF, dementia, and the liver dysfunction, for these people, they have level 2 because this is based on judgment from clinical people. That is, for these patients, they need to adjust the cancer treatment. Then for those with this index bigger than 0.66, then we say they have the level 2. Now, why this 0.66? You need to check the table. That is, all of these items in the second bullet had a value higher than 0.66, except the COPD. And amazingly, in the SEER, in the NCI comorbidity index, all of them are higher than 0.66. The remaining then have this level 1. Okay. Here is the result. I will walk through this figure, this one of the figures with you closely. Let's watch this. Let's watch this, the one on the left, upper left one. This is for localized breast cancer. You will find that there are 9 columns, and each column is divided into 3 parts: the darkest blue, the less darker blue, and the lightest blue. And the darkest blue is the probability of dying from breast cancer. And the middle one is dying from other causes. And the upper one is alive at the end of 5 years. So this figure shows that for localized breast cancer, the probability of dying from cancer is less than the probability of dying from other causes. And they all have a good chance to be alive. So this has some implication for cancer treatment. And similarly for regional breast cancer, and also for localized colorectal cancer, and 3 more minutes or 5 more minutes? Okay. Then I will talk about, with this development, we are in a position to study lung cancer. So in the year of 2011, National Health Insurance Program have this policy to reimburse a TKI for late-stage lung adenocarcinoma patients with EGFR mutation. Let's see consequence of this. Let's concentrate on the lower left figure. This is a 1-year survival, actual prognosis. You can see still there are 3 parts for each column. On the left is the survival for people diagnosed before 2010. And on the left, on the right is those diagnosed after 2011. You can see that the survival is better. after 2011. But when we consider 2-year survival, the advantage, the benefit isn't that much. But at the 5-year, then it's not so good. So I will make some final remarks. People talk about the incidence, survival, mortality, and the prevalence. But for survival, you can see that we need to consider age, categorized by age, sex, stage, cause, and comorbidity, and also period. But for incidence, we need also consider something more delicate. For example, we need to consider what's the lifetime risk. In US, it's 12%. In Taiwan, it's something like 6%. We made the risk study, but we haven't published it yet. And I have been avoiding talking about overdiagnosis. That's a very complicated and important issue. For that, we need this cause-specific survival. And also we need the, when we come to overdiagnosis or say for prediction, we need some information. For example, we have this information. The probability of lung cancer in the next 6 years among never smoking females is very small for a 33-year-old, but it is 1% for a 73-year-old. And this is one major component in the lung cancer prediction model that we published in 2020. The last page is about mortality. If you want to study overdiagnosis, we need the probability of dying from cancer in the next 6 years, for example, by age, period, smoking status. And here we need a good definition, good information, accurate information about the cancer death. With this, I think I'll finish my talk. And I have to thank Liu Chang. Many of the work I discussed with him, and also Xiong Zhao with her. And we have a very good young people to work with us. Thank you.
Thank you, Professor Chang, the wonderful talk. Because time limited, we only allowed one quick question from the audience. Professor Chang, maybe I can ask, what's your perspective about the President Li's ambitious goal to reduce the specific cancer mortality to about 30% in the future? So what's your perspective?
First thing we need to do is to make a good understanding of the current status. That is, for example, overdiagnosis, how serious it is. And the next thing is for lung cancer, smoking cessation is important. But for never smokers, I think we are working on it. We need a good risk model so that we can have a personalized suggestion for taking low-dose CT screening. That's, I think, the most important thing.
Thank you for your wonderful suggestions.